Hello and a very warm welcome to our own educational channel. And today we will talk about laparoscopic sterilization. And in our last lecture in part 10, we talked about tubal ligation and mini laparotomy in detail. And today we will know about what do you mean by lap sterilization, then what is informed consent, counseling and eligibility criteria, indication timings, and the method of lap tubal ligation or occlusion by fallope rings and clips, and destruction by electrocoagulation, then instruments required, then procedure to do lap sterilization, and then advantage, disadvantage and complications, and lastly most important part is comparison between the mini laparotomy and lap sterilization. So, guys, what do you mean by laparoscopic sterilization? It is basically occluding or destruction of fallopian tube by laparoscopy so that sperm and ova can't meet together to avoid the fertilization. So, some important points to be remembered are: number one, informed consent of the female herself is mandatory, but consent of partner is not at all mandatory. But it's better to encourage the partner to come along with the patient. So, remember this: consent of the female or the patient is only thing which is required. Number two is counseling. We have to counsel the patient before signing the form. Like, number one is we have to inform like all the temporary and the available permanent available methods, and it must be the voluntary decision of the female in her own language, and she must be told about the events which will happen before, during and after the surgery, then side effects, complications and failure of surgery. Second, we have to counsel the patient about the procedure, that number one, it is a permanent method. Number two, it considered to be irreversible, but nowadays it is reversible by a major surgery called as recanalization. Number three is it doesn't affect the sexual pleasure at all, and it doesn't affect the day-to-day activity of the female. Number fourth point is it does not protect against the sexually transmitted infections or HIV or AIDS. And last and the most important point is on failure or unfortunate death of the patient, monetary or indemnity coverage will be given to the patient, and it is approx 20,000 rupees in India. Then third is the eligibility criteria. Then who can undergo this procedure? So number one is couples must be married or ever married. Means either she is divorced or separated can avail this tubal ligation. Number two is female age must be above 22 and less than 49 year of age. Number three is couples have at least one child of age more than 1 year and living. Number fourth is there must be no any past history of female or partner sterilization. Fifth point, as I told you earlier, informed consent of the female in her own language is mandatory. Then sixth is she must be in the sound mind. If she is mentally ill, that need to be certified by a psychiatrist, and statement of ligation is given by spouse or legal guardian. Last is pre-op history of, like example, patient particulars like age, occupation, religion, number of children, then medical, any illness or immunization status or any contraceptive use, then menstrual history may last menstrual period, obstetric history may interval from the last pregnancy. And in examination, vitals and general physical examination, per abdomen, per speculum and per vaginal examination is done. In investigations, her hemoglobin must be equal to or above 7 grams per deciliter, and urine routine examination is done to exclude any infections. So these were the eligibility criteria given by the government of India. Then fourth is our indications of sterilization. Number one, if they feel their family is complete, either they have child one or two or three, depend upon them. Then second is if the medical condition of the female is worsened by pregnancy. For example, if she get pregnant again and she's endangering her life, like with the condition hypertension, diabetes mellitus, chronic kidney disease, or heart disease. Then third is if she is undergoing multiple cesarean section, because as the number of CS increases, there is increased risk of rupture or accreta. So lastly is the timings. In timings, main point is I want to tell you that laparoscopy is any time preferred over mini laparotomy except in two conditions. Number one is within the 7 day of delivery or 7 days postpartum, and in second trimester post abortal laparoscopy is not done. Then interval ligation, it is done on day 1 to day 7 of menses because it is considered to be the safest or infertile period as there are no chances of pregnancy. If it is done anytime, make sure patient is not pregnant, and we have to inform that there is increased risk of failure of this procedure. Then second is our postpartum period, that is after delivery. It can be done within the 7 days of delivery, but laparoscopy is not done, and after 6 weeks of delivery. In post-abortal, if it is a medical termination of pregnancy, then it can be done along with that, that is concurrent with the MTP. And if it is a spontaneous abortion, it is done ASAP till 7 days of spontaneous abortion. Number fourth is it can be done with any surgery like ovarian cystectomy also. So this is the anatomy of the tube. Let's revise it again. So ideal site of ligation is isthmus. So tube contains mainly four parts. Number one is our interstitial part, and number two is our isthmus part, which is the site of occlusion or destruction, and it is 2 to 3 centimeter from the cornua, or you can say it is the proximal or middle one third of the tube. Then third is our ampulla, which is the widest part, and fertilization occurs here. And fourth is our infundibulum, which consists of fimbriae, which used to collect the ova during the ovulation from the ovary. So next most important question is, what is the relation of fallopian tube to the round and the ovarian ligament? So we can remember by a mnemonic RFO. From anterior to posterior, R is round ligament, then our fallopian tubes come, and then ovarian ligaments come attached to the ovary. So it is RFO. So laparoscopic sterilization can be done by occlusion and destruction. So we will discuss the occlusion method first. It can be done by number one, fallop or Yun rings. They will occlude the tube, and these are the fallop ring, which are like hair rubber band, which are made up of silicone. And this is the most popular method of laparoscopic sterilization in India. Second occlusion method is by clips, which will cause only the compression of the tube. First type of clip is Filshey clips, which is outer line made up of titanium, and inner side it is made up of a rubber. Second is our Hulka Clemens clip, which is made up of plastic jaws containing the teeths, and it is had a spring loaded mechanism. So these both clips are applied with the help of applicator, As I told you, these clips will cause compression only, so therefore they will cause less damage of the tube, approx 3 mm. So there are high chances of reversibility of this procedure. Then second is by destruction by electrocoagulation. In this method, coagulation of the tube, or you can say tube is burnt and the burnt part is resected. It can be done by unipolar or bipolar. In unipolar, there is one blade only, so there will high lateral spread. Uh, therefore, there is high or more tubal damage. Therefore, least failure rate of the procedure. But there is more electrical injury to the pelvic organs as compared to the bipolar procedure. So, question came कि why unipolar with least failure rate is not at all popular, because as I told you, it creates more lateral spread and more tubal damage, so there is poor reversibility due to more tubal damage. So what are the instruments that are used for lap sterilization? There are 7 instruments we need to remember. Number 1 is our Viries needle, which used to create pneumoperitoneum. Second is trocars and cannula. Third is our Hulka's manipulator, which is used to manipulate the uterus by pervaginum. Fourth is our laprocator, used with the band applicator while doing the lap sterilization by single incision. Then is our the band ring applicator, consists of 2 parts. Number 1 is our scope and second is prongs. So prongs are introduced in the scope, becomes a band ring applicator. Sixth is our pusher, to push the fallope rings over the band applicator, and seventh is our loader, which is also called as a ring cone. And this is the image of a fallope ring over the loader or ring cone. So moving on to how to perform the lap sterilization. In this anesthesia, we can do this lap sterilization under general anesthesia or local anesthesia with sedation. Second is our position. Lithotomy position with 15-degree head down is made, which is also called as Treadnell bug position, as you can see in this image. And then catheterization is done to empty the bladder to avoid injury to the uterus, bladder. Then pervaginal examination is also done, so we have to manipulate the uterus. Then how to create the pneumoperitoneum. First, 10 ml or 10 cc of 1% lignocaine is infiltrate infraumbilically, and then 2 mm incision infraumbilically is given, and through this incision Viries needle is introduced at the 45 degree to avoid injury to the pelvic organs. Then pneumoperitoneum is created with 2 liter of carbon dioxide gas, with creating the 10 to 12 mm Hg of the pressure. So this question is frequently asked, which gas is used and how much pressure is created. After creating the pneumoperitoneum, trocar and cannula are introduced. So lap sterilization can be done by 2 methods, by single and double incision. In single incision, laprocator along with the band applicator is introduced with the same infraumbilical incision of Viries needle, which is extended from 2 mm to 10 mm or 1 centimeter. But in double incision, as the name is telling us, double means 2 ports are, 2 incision are given. First incision is given for camera port of 10 mm of infraumbilical incision, same incision of Viries needle of 2 mm, which is extended to 10 mm or you can call as 1 centimeter. Then this second port is made for band applicator of 5 millimeter in size, which is made 7 centimeter above and medial to anterior superior iliac spine. So After entering the abdominal cavity, we will inspect the pelvis and ask the assistant to antivert and anti-flex the uterus using the Hulka's or Vittu's manipulator, and ask the assistant to push the uterus to one side to stretch the structure so fallopian tube is visible. On the other side, assistant or prior to the surgery, we can load the fallopian ring. So, how to load the fallop rings? Number one, this loader is attached to the band applicator. This fallop ring is applied to the loader, and with the help of the pusher, fallop ring is pushed over the band applicator. So this is the example. This band applicator contains one fallop ring, and we can apply second ring simultaneously also. So this is the extended tip with one elastic ring, and this is the extended tip with two elastic rings. So how do we hold the band applicator in a syringe-like manner with fingers and thumb, as you can see in this image? And this band applicator contains a ring delivery selection collar containing number 1 and 2, which will I describe it further. So after stretching the uterus to one side, we will identify the fallopian tube by the fimbriae and move our fingers away from the thumb so it will open the prongs. So after opening of the prongs, we will hold the tube at the isthmus region, which is 2 to 3 centimeter from the cornus, and then we will move away the fingers from the thumb so it will close the prongs, and we will pull the tubes inside the lumen, and then we will release the ring over the tube. So if we have loaded both the rings together, first we have to select number 1 on ring collar selection delivery and apply the ring, and then select 2 to apply the second ring. But if we are loading only one ring at a time, then select 2 to apply the fallop ring. So this fallop ring will constrict at the base and decrease the blood supply and necrosis of fallopian tube. So this will cause the occlusion. So after checking the bleeding and abdominal cavity, deflation and removal of laparoscope is done under the vision, and it will complete our procedure. So what are the advantages of lap sterilization? It is a outpatient procedure and safe, and there are certain benefits from the lap sterilization, as it protects from the pregnancy because it is a contraceptive method, and pelvic inflammatory diseases also, as it will decrease the ascent of the infections. Then it will decrease the chances of ovarian cancer, which is also called as opportunistic salpingectomy, because a theory is considered that ovarian cancers occurs by the epithelial lining of the fallopian tube. Then third is there is less incision, less complication, and less post-operative pain and less failure rate chances. Then fourth advantage is there is high chances of reversibility because the remnant length of the tube is good, except the electrocoagulation, because here the tubal damage is more. Then there are some disadvantages of lap sterilization. As pneumoperitoneum is created, it can cause embolism and cardiorespiratory arrest. It is expensive, as you know, and trained surgeon is required. Then it is not done in postpartum, less than 7 days postpartum, and second trimester abortions. And this is contraindicated in heart disease, respiratory disease, abdominal carcinoma and hernia, and extreme obese patient. So discussing some questions. So as I told you all the procedures of sterilization. So can you tell me the best reversal chances are with? So number 1 is clips, because it only causes the compression as our hair clip. Then is our fallop ring. Then is our Pomeroy's technique. and then is our electrocoagulation. The second question is, what is the most common cause of failure of sterilization? Is the misidentification of the oviduct. We can apply the fallopian or anything on the round ligament. Then other are luteal phase pregnancy, means ovulation has already occurred, or incomplete occlusion, or improper technique. Then is are the incentives. How much incentive is given to the patient? It is in female sterilization it is 2200, and in male it is 2000 rupees, and they are increased recently, and motivator is given 300 rupees. Then talking about the complications, operative complications can be due to anesthesia or cardiorespiratory arrest. There can be injury to nearby structure, which are like bowel, bladder, ovary. Then bleeding can be there, which can lead to hematoma formation in broad ligament or mesosalpinx. Then post-operative can be remembered by a mnemonic WIF, that is WIF. Then W is wound. Wound can go under infection, hematoma, or dehiscence or gaping of the wound. Then I1 is infection, urinary tract infection or pelvic infection, and I2 is intestinal obstruction. I3 is incisional hernia. Then F is our fistula of bowel or bladder. In long-term complication, number one is ectopic pregnancy. As I told you, laparoscopic sterilization or any method decrease the chances of pregnancy. But if it is failed, then there are increased risk of ectopic pregnancy. Second is our post-tubal sterilization syndrome. In this, patient can complain of menorrhagia, dysmenorrhea, or intermenstrual spotting. Then their psychological problems are also seen after sterilization. And last is our comparison between the mini laparotomy and laparoscopic sterilization. So it can be remembered by a mnemonic DCP, that is District Commissioner Police, RCT, root canal treatment. So D is our definition. Mini laparotomy is a 2 to 3 centimeter long incision sterilization, and laparoscopic is a single or double incision sterilization of 10 or 5 millimeter. C is our cost. Mini laparotomy is cheap compared to laparoscopic sterilization. Then C is our contraindication. Laparoscopic sterilization is contraindicated in heart and lung disease, abdominal carcinoma and hernia, and extreme obese patient. Mini laparotomy is done if laparoscopic is contraindicated, and there is no contraindication of mini laparotomy. Then P is our personal, which person can do which surgery. So mini laparotomy can be done by MBBS with training of tubal ligation, and lap sterilization must be done by MS, TGO or surgeon. Then P is place. Mini laparotomy can be done in camps, but laparoscopic sterilization is not done in camps. Then R is our reversibility, which is difficult with the mini lap because of adhesions, and remnant tube is less in mini lap. Laparoscopic sterilization is easy as it will cause the less adhesions except the cautery, and remnant length of the tube is more in lap sterilization. Then C is our complication, which are minimal or absent with mini lap, but also laparoscopic sterilization, but they can be fatal at times. Then mini lap can be performed any time, and laparoscopic sterilization is not performed postpartum less than 7 days and second trimester abortions. So it can be remembered by mnemonic DCP ka RCT. So last is our talking about something very effective, that is side effects of maida or refined wheat flour. So I request you all to decrease the diet having containing the maida, because it can cause any digestive problems, increasing the sugar level, causing diabetes, obesity, heart problems, and it is low in nutrition, which will weaken your immunity, and is also harmful to the gut, which will cause you digestive problems. So try to avoid these things made of maida or refined wheat flour. For example, white bread or naan or bhature or cakes, pastries, biscuits, cookies, toast. Then our sandwiches, wraps, noodles, momos. Sorry to say, but I think we must focus on our health also. And samosa, kachori, noodles. And there are different products coming, and people are focusing on their health, so please try to avoid the maida items. So let's revise our today's lecture, that is laparoscopic sterilization. So informed consent of the female is mandatory. Then counseling is done before signing the form and about the procedure, that it is a permanent and reversible and doesn't affect sexual pleasure, day to day activity, and not protect from STI. And on death or failure of the procedure, monetary coverage is given. The eligibility criteria में couples must be married or ever married, of age 22 to 49, having at least one child of age more than 1 year and living, with no past history of female and partner sterilization, with informed consent and sound mind of the female, with pre-op history examination and investigation. The indications में family, complete family and medical conditions are there which worsen the condition of the female with pregnancy, and the patient is undergoing multiple CS. Then timings में laparoscopy is any time preferred over mini lap, and in interval sterilization done under day 1 to day 7 of menses, postpartum within 7 days and after 6 weeks, but laparoscopy is not done in within 7 days. Then post abortal may concurrent with the MTP, or if spontaneous abortion then ASAP till 7 days. And most ideal site for ligation is isthmus, which is 2 to 3 centimeter from the cornea. Then laparoscopic tubal sterilization by occlusion done by fallopian rings, most common method of lap sterilization in India, and by clips, that is Filshey and Hulka Clemens clip, and by destruction is electrocoagulation by unipolar and bipolar. Then 7 type of instruments which are used are Viris needles, trocar, cannula, Hulka's manipulator, laprocator, band ring applicator, pusher, and loader. Then GA or LA is given in Trendelenburg position. Pneumoperitoneum is created, introducing the Viris needle at 45 degree with 2 liter of CO2 at 10 to 12 millimeter of mercury. Then single incision or double incision is given, and in double incision 10 mm camera port is introduced infraumbilically, and 5 mm band applicator is introduced 7 centimeter above and medial to anterior superior iliac spine, entering the abdominal cavity, asking the assistant to antivert and antiflex and push the uterus to one side. Then how to load the fallopian ring. Loader is applied to band applicator, then fallopian ring applied to loader, and with the help of pusher, fallopian ring is pushed over the band applicator. We can load 1 and 2 rings simultaneously. Then after identifying the tube by fimbriae, we have to move the finger away from the thumb. It will open the prongs, and holding the tube by the isthmus, close the prongs and pull the tube inside the lumen and release the ring over the tube. So best reversal chances is with clips because they cause only compression, then fallopian ring, then pomeroys, and then cautery. And most common cause of failure is misidentification of fallopian tube, as we can apply the ring or clips on round ligaments. Incentives in female sterilization, patient is given 2200 and male 2000 rupees, but motivator is given 300 rupees. And complications में post operative we can remember this by a mnemonic WIF. And then comparison between the mini laparotomy and lap sterilization can be remembered by a mnemonic DCP RCT, that is District Commissioner of Police undergoing RCT, root canal treatment. So guys, this was my video on lap sterilization, and I am getting your love very much, like I am getting appreciated for my work, and you all keep me motivated. Thank you so much.